Hello, how are you today? Welcome to the world of ophthalmologic imagery. We're going to show you the most basic of ophthalmological images today, showing you the routine pictures of the eye examination that are most likely to be shown to you on step 2. I'm Conrad Fisher, and I'm the Associate Chief of Medicine for Education at SUNY Downstate in Brooklyn, New York. The most important part of our investigations is to look at what the normal retina looks like. The normal retina should have predominantly a beautiful, clean, clear space in between the blood vessels. You will see here as we examine the image, the normal blood vessels coming out make up only a small part of the retinal surface. The majority of the retinal surface is free of blood vessels so that the light can penetrate. The same way that you can't look at things through your own eyes if you got rolls of dough in front of your eyes. How's the light supposed to penetrate to your own eyeballs? The majority of the retina should be with clean, orange, reddish background that does not have any hemorrhages, dots, blots, or snots. Big blood vessels should not be occluding it, and the basic thing should be a clean, clear surface through which light can penetrate. The most important image for us to evaluate here is the normal retina. Again, to show you variations on a theme between the retina, so that when you see the abnormal retina, it'll become much more obvious to you if you are familiar with what a normal retina looks like. Again, on our next image, it shows again, even though some of the blood vessels might be relatively large, that the space in between those blood vessels is clean, clear, no hemorrhages. The external surfaces of the blood vessel you see are smooth and even. There are no aneurysms bulging off of them. Aneurysms block the perception of light. There's no hemorrhages in the vitreous. Hemorrhages in the vitreous are like eclipses where your moon goes near the sun and blocks out the light as it shines upon the earth. The earth would be like the retina. The moon, as causing an eclipse, would be blocking the sun, and you would form a large shadow on the earth, eclipsing the sun. So it is with all the hemorrhages and things inside the vitreous chamber. The more of those you have blocking sunlight, the less you're able to perceive light on your posterior retinal surface. Now, looking at our images again of the retina, we see that the majority of the retina is clean to perceive light, and here, with the optic nerve head, you'll see at the optic nerve head, still the majority of the optic nerve head is clean of blood vessels. This is how you'll tell the difference between this and diabetic retinopathy. The majority of the optic nerve head is clear of blood vessels, and here inside the macula, or the fovea, where the majority of the retinal sensory epithelium lives, you have virtually no blood vessels, because this is where most of your vision occurs. You could damage out here in the periphery and still see. You could damage out here in the periphery and still see. But the density of retinal receptors, rods and cones, is here centered around the macula or fovea, where the highest density of retinal light receptors are concentrated. Let's look at our first disease, diabetic retinopathy. Now, background retinopathy means that there is a very small deterioration in the blood vessels of the retina. However, there's not enough to occlude the perception of light. As a matter of fact, background retinopathy is not perceived by the patient in the majority of cases. It's something that is found on a routine eye exam. That is why diabetics, let's write something up on the board here, that is why a diabetic should have his feet and his eyes examined every year. Now, personally, I wish that we can combine podiatry and ophthalmology. I've only succeeded in combining podiatry with dentistry because I have my own foot in my mouth so often. I've managed to combine both specialties, because both the foot and the eye should be examined every year. Now, the eye exam is done so that when you see background retinopathy, you can intervene perhaps with laser photocoagulation as the disease worsens. So the point about diabetes is to examine these eyes so that you can intervene to prevent the progression onto quote-unquote proliferative retinopathy. Proliferative retinopathy means that those small hemorrhages have progressed to the point where they're clouding the epithelium, they're blocking the perception of light. Background retinopathy is little dots, blot hemorrhages, no neovascularization. Neo, new, blood vessel formation. No vitreous hemorrhages. The background means behind the vitreous, in the retinal epithelium itself. Dot and blot hemorrhages, but not neovascularization or vitreal hemorrhages, which act as an eclipse. This is in the background. It blocks a little, but not very much. Small blood vessels. Now, also, the other thing about the damage of the diabetes to the eye is that here we have a blood vessel. Here is a blood vessel that is supplying the epithelium of the retina. And here's the blood vessel supplying the epithelium of the retina, and here are the cells above the blood vessel where they're being supplied. And don't mind my artwork here, which doesn't look consistent. I'm just trying to show that basically the blood vessels in the eye are underneath the layer of epithelium and the rods and cones above it, the same as it is an underground irrigation system. Basically, this is further back of the eye. This is where the light is coming. The light is coming in this way. The light is coming this way to be perceived by the retinal epithelium. Now, the blood vessels are underneath the retina, simply supplying it like an underground series of pipes in an irrigation system. This is more like agriculture. Now, normally the blood vessels have an endothelial lining, which protects it, feeds it, keeps it nutritious, and that is normal. And then the blood goes down this endothelial lining, and the blood goes down here and feeds the retina. And feeds the retina and supplies oxygen to it. That's normal. If it sounds boringly repetitive to you, like something you know, good. That's the whole point. Now, the fundamental defect in diabetes, no matter where it is in the eye, whether it is in the retina, the kidney and nephropathy, the brain, the eye, the kidney, or the heart, is fundamentally the same defect. The endothelial lining gets damaged. Now, if the endothelial lining starts to become damaged as 1 year, 5 years, 10 years, the endothelial lining starts to become even more damaged, and the sugar itself at 10 and 15 years starts to significantly narrow and become damaged as the endothelial lining becomes destroyed. Now, how can blood get down the blood vessel if the endothelial lining gets damaged? So what happens is liquids start to seep out, lipids and liquids start to seep out into the retinal epithelium, and this would be known as part of the background retinopathy, or if it's lipids and extracellular fluid, as cotton wool spots. Like putting your hand in dough, squeezing the dough, and the dough comes out between your fingers. It's pressure. Now, the distal retinal epithelium is over here. The distal retinal epithelium is down here, and it's not getting enough perfusion because it's only getting a trickle of blood going through it. And the distal retinal epithelium is very sad. And the distal retinal epithelium goes, oh, how am I going to get any blood vessels down here? And the distal retinal epithelium is very sad and says, help, help, can you send me some blood, Mr. Blood Vessel? And it says, help, help. And the blood vessel says, no, I'm all clogged up. I don't know what to do. I've got blood vessel constipation. It's not like I wouldn't like to go, but I'm all stopped up. How am I supposed to get to feed the poor Mr. Blood Vessel over there? Oh, he's very sad, very sad, very sad. Look here. Tristetas et lacrimis, as they say in Latin. So what happens is that help sign goes, and it goes dun 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 dun. Angiogenesis factors. Angiogenesis factors are released to go backwards and says, let's start making some new blood vessels. If this blood vessel is all clogged up, let's make some new blood vessels so that we can feed that retina. And new blood vessels get formed, and that's how you have background retinopathy progressing on to proliferative retinopathy. The epithelium is dying. It says, help, help, I'm not getting enough oxygen. Angiogenesis factors are released, which get the blood vessel to form new, neovascularization. Now, the problem with that neovascularization is that part of it is that it blocks the retinal epithelium. The other part is that the rest of the blood vessel starts to form small aneurysms because the blood vessel starts to bulge out. And when the blood vessel starts to bulge out with those microaneurysms, that's also partly is what's known as microaneurysms. Sometimes the blood leaks out. You actually have blood leakage out because there's back pressure. This is obstructing it. The blood's trying to go forward. There's back pressure. And the blood vessel starts to go aneurysms. And the blood vessel sometimes goes boop, and you start to get a little hemorrhage in the epithelial cells, microaneurysms, dot and blot hemorrhages, all based on back pressure. Neovascularization from the from the retinal epithelium going, help, help, I'm not getting enough oxygen, rescue me. And that's the whole story. Now, back to the images here. Let's again look at our normal retina. The normal retina is mostly free of blood vessels, particularly at the macula, where the majority of our retinal epithelium is, where we can see with. We could live without this stuff on the periphery, but you can't live without your macula. As a matter of fact, the most common cause of blindness in the Western Hemisphere is age-related macular degeneration. Age-related macular degeneration. So, when the retina starts to get sick, you start to see here small dot and blot hemorrhages on this image of the retinal epithelium. Now, there's no actual treatment right now, but as it starts to get worse, you can see that although this may look like a picture of astronomy, that we're looking at as a picture of Mars here, and there's the polar ice cap of Mars, as the eyeball starts to get damaged, you can see more hemorrhages leaking out of blood here into the retinal epithelium, more leaking out of fluid, more fats leaking out and blocking the epithelium, more blood vessels blocking the epithelium. And here you see, this is still things just in the background, where you have extravasated fluid blocking the epithelium, the blood vessels start to break down, blocking the epithelium, but it's only when it becomes very severe at proliferative. What is proliferating? The new blood vessels. As we see here, the nice, neat cup and disc, the cup sits in the disc, now starts to get obscured with all these new blood vessels. Also, how am I supposed to see when I've got all of these blood vessels over my epithelium? How am I supposed to perceive light? This would be like being in the woods. I'm trying to look through the bushes to see you, and these thick hedges are growing in front of me. Do you see me? I don't see you. Well, I can't see you because I got all these blood vessels getting away. Would you get these blood vessels out of... Hey, I can't see you. Every time I turn around, it looks the same. Yes, because I can't see because these neovascularization blood vessels are still in my way every time I move my eyes. This is when it's more advanced and it starts to damage the surface of the retina. Once you have neovascularization and once you have a vitreous hemorrhage, such as occurs here, you can see that the majority of the retinal epithelium starts to get obscured. How can I perceive light when I got a big drop of blood in my vitreous? Now remember, a drop of blood may seem small to you, but a drop of blood obscuring your eyeball, which literally has millimeters of surface area, millimeters, is huge. Therefore, the treatment at the beginning is always aimed at controlling the blood sugar. There is no question that the percentage of retinopathy, has to do with whether or not you want to call it the average glucose level. As the glucose level on average goes from 100 to 200 to 300, if your average glucose level rises up, there is no doubt that there is a marked increase in the frequency of retinopathy over time. Now, if you want to call it hemoglobin A1C, both of these are valid. If you want to say hemoglobin A1C of 6%, 7%, 8%, 9%, the same is true. The greater the average glucose, the greater the average hemoglobin A1C, the more likely is someone will develop retinopathy. If you say percentage with retinopathy at 5 years or 10 years, the higher the glucose, the greater the percentage with diabetic retinopathy. Aspirin will not help. Aspirin does not stop that neovascularization. Aspirin can only hurt a person who's got an ocular hemorrhage. Aspirin will not help. At what LDL would you give a statin medication to for a person who's got this diabetic retinopathy? The answer is anybody with an LDL greater than 100, an LDL greater than 100 for sure should be on statins, because diabetes is considered equal to coronary artery disease. So anybody with a statin LDL above 100 should be on a statin, just because of diabetes. Just with diabetes. Above 100, put them on a statin as a single risk factor. Controlling lipids and controlling glucose will help you, but by far the most important thing is controlling glucose. Aspirin does not help. Now, once the person starts to look like their background retinopathy is getting worse, laser photocoagulation will zap out the cells producing the angiogenesis factor. So the idea is that as you do the photocoagulation, you're going in the back of your retina to destroy cells that are going to make the angiogenesis factors. If you don't make angiogenesis factors, you won't form the new blood vessels. Now, we all want to get blood vessels, but not at the expense of blocking light going into my retina. Now, a separate subject, retinal detachment. Retinal detachment is the mechanical removal or loss of the attachment of the retina on the back of the wall of the eye. Now, the retina is attached to the back of the sclera. The retina is attached to the back of the sclera. Here's the nerve going out the back of that orbit. The retina is attached to the back of the sclera. Now, it's like wallpaper. If you have the retina attached to the normal sclera, life is good, but there are two separate epithelial layers. There's two separate layers there. And sometimes you get the retina detached from that sclera the same way you could pull wallpaper off the wall. Now, the things that would pull it off is one, bang, knocked it off, trauma, knocked it off, got banged out by trauma. Turns out to be also that diabetic retinopathy is not so good for the life of that retina, and it puts tension on it. As the neovascularization and scarring forms, the retina goes, and the scarring of the retina puts tension on it and can pull it off. Even people with myopia can have extra tension on that. People who have surgery for cataracts, they're getting their ocular lens. They're having an intraocular lens put in, and as their intraocular lens gets put in, what happens is that sometimes that trauma to the eyeball from the placement of the intraocular lens can result in trauma which dislodges the retina. Now, the most important thing is that retinal detachment is a loss of vision that is, one, sudden, but painless. Painless. Uveitis pain, glaucoma pain, conjunctivitis pain, abrasion is pain, glaucoma is pain, and uveitis is pain, conjunctivitis pain, and abrasion is pain. But this is painless. Flashers and floaters is because as pieces of that epithelium get damaged, part of it starts floating around in the vitreous. And anything that provides tension on the retina can give flashes of the perception of light, the same way if I go into an electrical box in your house and I start jerking around the wires, I can cause sparks in a short. Pull the retina, this is electrified epithelium. Wow, kind of like an electric blanket. On one part of it, it's warm and soft and fuzzy. On another part, it's got electricity running through it. If you tug on it, you can cause a short in the wires, and you can pull the epithelium off. And these floaters are pieces of epithelium floating around the eye, so as the image tries to come into the eye, dog, happy, happy, dog, 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 human head dog, as the dog tries to be perceived coming in there, how can you see it? Because flashers and floaters start getting in the way, and the tugging on the epithelium causes you to perceive flashes of light because the epithelium is getting tension on it that does not belong there. So that's why the red cells are in the vitreous, because it blocks the light. Remember, it's not red and it's not painful. Now, retinal detachment, the best initial therapy is simply if the retina has come off of the sclera, if the retina has dislodged off the sclera and it's now floating around out here loose. The first thing is, ready? Tilt the head back. And the idea of tilting the head back is that if you get this eyeball to tilt back, the idea here is that we think that the retinal epithelium will want to just float itself back here and float back on to the back of the sclera. Now, what if it doesn't do that? Then what you have to do is get in there and surgically reattach it and tack it up. Surgically, little points of freezing, laser, let's staple it back on there. Oh, the wallpaper's fallen off the wall. Let's push it up, tack, 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 tack. No, it's your eyeball, man. It can't be like that, tacking on wallpaper. You're right, because if it's just your wallpaper, it wouldn't cost $35,000. Okay, so that's why you lean it back and tack, 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 laser, cryotherapy, surgery, moving it back. Now, one of my favorites is, if you can't get that nasty epithelium to go back there, because it just won't go back, let's put a needle in here and let's inject some expansile gas. Don't you like that? Let's inject a little gas in there. And the gas expands, and the idea is that this expansile gas, putting an air bubble in there, is supposed to slam the retina back against the wall where it goes back with pressure pushing against that sclera. The retina is floating around. I don't want to go back to the sclera. I like floating around here, but we can't see. Oh, I don't care. I'm having a good time floating in the vitreous. Really? Let's put a needle into the eyeball, into the globe. Sclera, retina, sclera, retina. And how do you get the retinal epithelium to reattach to the sclera sometimes? You put in an expansile gas and damn. All right, I'll perceive light for you, but I don't have to like it, do I? And that's how you get the retina pushed back. Expansile gas, laser attachment, cryotherapy, surgical reattachment. Now, sometimes, no matter what you do, It's like in relationships. No matter what you do, you just can't seem to make it fit right. Now, the retina wouldn't go back to the sclera. So what can you do if all these different forms of couples therapy end up not working? I try to tack the relationship together, freeze the relationship. I tried to be hot in terms of heating it up, laser. I tried to be cold once, cryotherapy. I tried one time just to force it together with surgery. I tried to push in with other couples and pushing it together. It just wouldn't reattach. Well, if I can't get you to move back closer to me, let's put a buckle around this. You like that? Like a belt. Let's put a belt around the whole thing. Put a belt around the whole eyeball. Put a belt around the whole eyeball and tighten that up and pull the whole sclera forward. And that's how we make the sclera reattach sometimes. We take a scleral buckle and put it around the eye and force the sclera to move forward and contact the retinal epithelium. If you can't get the retina to go back, we can take the sclera and scrunch it down, make it tighter, make it tighter, scrunch this down tight, and pull the sclera forward and make it reattach. Next disease. The next disease is macular degeneration. Now, macular degeneration is simply the loss of the retinal epithelium at the area of the macula or the fovea. Now, I'm very sorry to say that the most common cause of blindness in adults in the United States is age-related macular degeneration. Diabetes is very close to that. Now, that just means that the macule, in other words, the area of densest light receptors, starts to get damaged. Now, it's divided up into two forms. There is a dry type, and in this dry type, yellow material released in the retina called drusen start to obstruct the perception of light by obstructing the retinal epithelium. Now, there's a quote-unquote wet type, which involves new blood vessels. And the new blood vessel formation can be treated in some ways like diabetic retinopathy with laser photocoagulation. There is no proven evidence that any therapy will definitely stop the progression of dry macular degeneration. However, we can try antioxidant vitamins like vitamin A and vitamin E, and antioxidant vitamins. We can try vitamins A and E and antioxidant vitamins. We can attempt to use antioxidant vitamins to try to stop the progression of the retinopathy with the macular degeneration. However, it's not proven. Wet type macular degeneration can be improved with the laser, and all of them should receive vitamin A, C, and E. However, this has the best evidence for being able to be used to stop the progression, but only of the wet type, which is new blood vessel formation. And therefore, we can do angiography of your eye, or we can use verteporin, which is a light sensitizer that can let us know where we should be doing the laser photocoagulation. Age-related macular degeneration, no proven therapy. Wet type with new blood vessels, use a laser. Dry type with drusen, antioxidant vitamins, vitamins C and E and sometimes A. Next disease. The retinal artery and the retinal vein can both become occluded. The retinal artery and the retinal vein can become occluded in the same sense as having a pulmonary artery or deep venous thrombosis. So central retinal artery and vein occlusion can be distinguished because since vein occlusion will block the venous outflow of the eyeball, you can determine it by looking at the image and seeing blood extravasated into the back of the eye. The blood vessels have blood in them. Why? Because the arterial supply is normal. The blood's getting in, But since there's a vein occlusion, the blood can't get out, increased pressure, and pop, the blood goes into the background of the eye. You get blurry vision. It is not painful, neither in retinal artery nor in retinal vein occlusion. There is no specific therapy for vein occlusion. You cannot heparinize, because if you heparinize someone bleeding into the back of their eye, you can make it hemorrhagic even more and blind them. No specific therapy. How do you tell them apart? Vein occlusion extravasates blood, and artery occlusion does not. See these new arteries? Let's look at this image of the normal arteries again. You see the normal arteries with this nice, plump, juicy, tasty, healthy-looking blood vessel supplying the retinal epithelium. Now, if you have an occlusion of the artery as it's coming out of here at the optic nerve head, the artery goes down the center of the optic nerve, right down the center of the optic nerve. And if it becomes obstructive, it's rather like a stroke. Watch what happens to these red, jummy, juicy, plump blood vessels. Oh, they're pale, milky, sudden. Why? Clot goes to that blood vessel, obstructs it, no blood goes into it. How do I know this is an arterial occlusion? Because there's no blood coming into the arteries. There's no blood going into the arteries, therefore it is pale. If there's blood going into the arteries, there's blood extravasated into the background of the eye, and you actually see blood drops in the back of the eye, retinal hemorrhages from the vein occlusion. In artery occlusion, everything's pale. There's no blood in there. You try to treat it in many ways the same as you would a stroke. Thrombolytics occasionally, trying to use aspirin and heparin to dislodge the clot, sometimes even eyeball pressure. The retina is pale because there's simply no arterial blood supply.